There we go. So again, thank you everybody for joining us today. My name is Mark Driscoll. I am the program manager for the Preventative Health Program. Just a quick note from me, and then we will kick it off to our speakers. If you are applying for CME or MOC Part 2 after today's presentation, I will send an email, hopefully by the end of today, if not early tomorrow, with the link to apply for both CME and MOC Part 2. So you'll get that in the email that comes after the presentation today. Otherwise, if you have any questions after the presentation, please feel free to reach out to and email me. And then without further ado, I will kick it off to our speaker, Dr. Shan Yun.
Okay, thanks. Yeah, so we're going to be talking about marijuana, nicotine, and kind of in how that impacts our youth, particularly adolescents. So I have no really relevant financial disclosures. I do receive royalties from Wolters Kluwer for authorship of up-to-date chapters, but they're unrelated to this topic. I also I will, I guess, mention some off-label use of medications, and I'll point that out when we get to that. So the objectives are to describe some new products available to children and teens that deliver cannabis-based and nicotine-containing compounds. We'll kind of go through the hazards of cannabis and nicotine use, especially in adolescents, and then employ some strategies that might help prevent teen use of cannabis and nicotine-containing products. Um, so I am the medical director of one of the two poison centers in Ohio. And so I just point out this toll-free number. This will get you to any of the poison centers in the United States. And so we're always available 24 hours a day to help you with any kind of assistance or anything in terms of managing acute poisonings. So there aren't a lot of new products per se, but there are a couple recent developments. So one is that in May of this year, the FDA did basically expand. So this headline is from their release. FDA expands market access, authorizes new ends products. So basically, what they did was so previously, fruit flavored cartridges had been banned by the FDA, and so basically in May of 2026, they've allowed for products now uh, on the market that are fruit flavored. And so those are, you can see those below. There's the menthol, the fresh menthol, and then gold and sapphire, which I believe are blueberry and some other fruit flavored. Um, so, so like I said, previously the FDA had banned fruit flavored in rechargeables, but there was a loophole essentially that if they were disposables that essentially they were allowed. And so and then not a lot, but a number of states had individually banned those as well. And so I will admit that I'm not always the best at navigating at what the current law is, but I believe that Ohio did not. And so that you could, even before this, you could get fruit flavored disposable products in Ohio. And I think there were also a number of just kind of non-authorized products that were kind of available either via the internet or other things. But this is a change, and that's again the FDA is allowing specifically these fruit flavored rechargeables back onto the market. And we do know from literature that these are more attractive to children and teens. And then the other kind of newer development as well, and again, this you could see this occurred this year, is that the FDA is allowing, so this is allowing the marketing of nicotine patches, nicotine pouches. And so these were available, but you couldn't market them, and now the FDA has allowed these to be marketed. Um, Oh, I should say one thing. I forgot to mention about the fruit flavored um, rechargeables. So along with that, the FDA there is essentially I guess there's an app that goes along with it that you have to be over 21 to use, and so somehow the app interacts with the device. I mean, I haven't used that, and I'm going to guess that there are probably ways around that, but that's one of the things that was stipulated with that those the release of those products was that they had to be for people over 21, and that there was like this app that would kind of connect with the device that would make it so people under 21 couldn't use them. All right, so I don't think this is anything new to you guys that the state of Ohio legalized the recreational use of marijuana in 2023. Um, this I haven't updated this slide in a while, so I'm not sure if it's exactly true right now, but at least it was a few years ago that it was legal in 40 states. In Ohio, it was medically it was legal from a medical use in 2016 and then recreational in 2023. So specifically looking at cannabis, I just wanted to point out a few things. So um, the Farm Bill of 2018, which is a federal law, basically removed hemp from the Controlled Substances Act, and that was defined as containing anything less than 0.03% of delta 9 THC. And so when we talk about THC, delta 9 THC is what we think of. That's the major psychoactive component of the cannabis plant. So there are over 100 cannabinoids in that plant, and there's probably over 500 compounds. But the main kind of, when we think about people smoking pot, the main compound that we're talking about is delta 9 THC, and you could see the structure there. And just a little bit. So cannabis or delta 9 THC and other cannabinoids, they're basically agonists at either CB1 or CB2 receptors. Um, and just from a kind of science medicine standpoint, these are interesting in that they're fairly recently discovered. I mean, CB1, the CB1 receptor was discovered in 1988, which I guess was a long time ago now, but seems very recent. And we didn't know that there were any endogenous ligands up to that point. But the first one was discovered in 1992, and that's that one ANA. And then a second one was discovered in 1994. That's that one 2AG. And they both bind to CB1 and CB2 and another receptor, TRPV1. Um, and I will point out that cannabidiol or CBD is not a CB1 agonist. Um, and then the other interesting thing is that CB1 antagonists are under study. And so I think that at some point in the near future, there will be essentially something akin to a naloxone that you might give, especially like a 2-year-old or something who had gotten into THC. And then I'm sure you guys were aware that there were a number of other products that were essentially legal. And so the big one was Delta 8. And so on basically Delta 8 was the exact same as Delta 9, except the double bond was moved over. If you look in the structure, that's showing Delta 8. And so the double bond in that top left ring structure is moved one over. And then Delta 10 is the exact same, except the double bond is moved one over. And so these were legal because, again, the Farm Bill said that anything that contained more than 0.3% Delta 9 was illegal, but they didn't say anything about Delta 8 or Delta 10 or this other one, THCA. And so those were all technically legal under the Farm Bill. And Delta 8 we knew was basically the same as Delta 9, except that it was less potent. So it was about 50% as potent. Um, Now they were banned by the governor in October of 25, and then basically blocked the next week by a judge in October 14th. But then the Ohio legislature subsequently did ban these in March of 2026 via Senate Bill 56. Cannabidiol remains legal. So, I mean, these were a real problem, especially these Delta 8 and Delta 8 products, because they often were marketed in things like this. So these are not candy, these are all THC products. And you can see that they look extremely similar to candy and other things that kids would eat. And again, these are products and not candy. And so this was obviously a big concern in terms of little kids getting into these. So this is data from the both the Ohio Point Centers combined. And so this just shows that um, the blue line being young children, 0 to 5, exposures to cannabis products. And we can just see that as they have become more, once they become legalized, we just see the incidents go dramatically up. And this is nothing new. We could have told you this was going to happen because this is the same pattern that appears in every state that legalizes marijuana in some degree. So Colorado being the first, the same thing happened. You'd see exposures in little kids kind of skyrocket. I mean, exposures in young children, poison center exposures in young children, kind of that 0 to 5 age group, largely reflects availability in U.S. households or in households. So again, national poison center data reflects availability in U.S. households. Ohio poison center data would reflect availability in Ohio homes. So anytime a product is more available in a home, it's very likely that young children will get into it. This is figures from the Monitoring of the Future survey that's done annually and published, and it's probably the best data on kind of national teen and middle school use of different products. And so the top figure just shows kind of the asking the high schoolers, 12th graders, if they thought using cannabis was a big risk. And you could see that basically that it started to drop. Like, so if they were saying that regular use was a big risk, that it started to drop, meaning teens didn't think that it was as risky. Now, has been an uptick more lately, so that could be a good sign. Um, and then the bottom figure is just if using it, this is all high schoolers, and then just using it once or twice if that was a great risk. Um, and we could see probably it looks like it's also had trended down a little bit and maybe trended up in the recent past. And then this one is just saying that if they have used or if they've ever or used regularly or occasionally or once or twice, and we can see that it did trend down and then again trending up, and then disapproval in the bottom, and again trending down and then trending back up. And then this is lifetime prevalence, um, and that here for 12th grade, 11th, 10th, 9th, 8th. And we could see that again that it might have been trending down since the early 90s. And again, it starts to, we lose the data up until the more recently. And then this is for daily use, same type of pattern. And then this is for vaping, specifically vaping marijuana. Um, And so again, it just started very recently. And so there's not a lot to go on so far, but we'll see in some other slides here that vaping at least is a big concern for the vehicle. And that's right here. So this is from the CDC, their National Youth Tobacco Survey. So this is U.S. high school and middle schoolers in 2024. So 8% of American middle school and high school had ever used some tobacco product. or sorry, this is current use, so that means in the last 30 days they've used at least once. And then you could see that e-cigarettes make up about 75% of the total use. So that is going to be by far the most popular vehicle for U.S. middle school and high schoolers to use a tobacco product. We see nicotine pouches are second, and then really combustible cigarettes and cigars are third and fourth there. So this is from Ohio has a survey as well, and this you could find this data on the Ohio Department of Health website. So this is again percentage of high school students. So same thing currently use um, this so specifically an electronic product. So this is once at least once in the last 30 days. We can see here Ohio total is at 18.8%. And again, I'll just point out that for the national high school um, would be about 7.8%. So Ohio is much worse than the national um, percentages. And then this again is Ohio. Percentage of high schools currently smoke cigarettes, again, once in the last 30 days. And Ohio's totals at 3.6%. Again, that for the national, for both middle school and high schoolers, again, was at 1 point something. So Ohio, again, is much worse than Ohio, the national statistics. All right, we're going to go over some of the kind of hazards of both THC and nicotine. So from a short term, this is specifically, we're just looking at little kids here, and this is data from this was a publication in pediatrics, and this was actually National Poison Center data, and so primarily we were seeing it kind of hit these kind of main organ systems: neurologic, cardiovascular, GI, ocular, respiratory. And so neurological symptoms are by far the most common, and with some degree of CNS depression, all the way from kind of just being a little loopy and acting high to being completely comatose, GCS3 needing to be intubated. And so again, all of these little kid exposures, the vast majority of them are going to be from edibles, right? So not from kind of secondhand smoke or anything like that, but from eating a cannabis edible. Um, and so um, yeah, so by far the most common will be kind of CNS depression primarily, but they could just be acting a little loopy, or even again, parents will say they just look high, and this will be certainly dose dependent. Cardiovascular symptoms are common. So tachycardia is in fact the most common sign or symptom, um, and was seen in about 11% of cases. Now, if you look at like adults and teens who smoke, it's much higher. It's something like at least 70% will be tachycardic. We don't really expect to see kind of more worrisome dysrhythmias, bradycardia sometimes, and then every now and then you had some hypotension. Respiratory depression is it can occur. It's uncommon. Again, mostly CNS depression, but respiratory depression can occur. Vomiting is not uncommon. Sometimes we'll see meiosis, and so sometimes you might be confused that they look like an opioid because they're CNS depressed with small pupils. And then other things like electrolyte abnormalities, metabolic acidosis, urinary retention are very, very rare. They again there were a few cases in this case series of poison center cases. One thing that's important is that the onset can be delayed for so the a little 2-year-old might eat one of these, but then not become significantly symptomatic for some hours later, which is different, obviously, than if you were to smoke THC, that you are symptomatic very, very, very soon. And so that is just something to keep an eye out that these little kids, again, may not be significantly symptomatic for a little bit of time and will be symptomatic generally for longer than if you had smoked THC. Good thing, usually, like the kids who are GCS3 and get intubated, usually they're extubated by about 24, 48 hours at the most, and then complete recovery. There is a DSM-5 definition for cannabis intoxication. One thing I just want to, and this is not, this is would be used for adolescents or adults. And again, the one thing I would point out here that tachycardia is essentially one of the criteria in this. So a lot of people just don't think that that smoking THC, people just think, oh, it mellows you out and that type of thing. But again, tachycardia is the most common kind of derangement in your vital signs. Nothing that necessarily needs to be treated, but just don't be surprised if they come in tachycardic. All right, so one thing that is, I would say, a more recent development is psychosis. So this is these are figures from a paper in psychological medicine. This was looking in specifically in Denmark. And these figures are basically the number of cases and then the incidence rate of psychosis with these products. And so cannabis is kind of the shorter dotted line. And so the one that's kind of rising is cannabis. And so, yeah, so there is data that there are more cases of psychosis. And I would say anecdotally, that is our experience in the United States, that we're seeing much more cases of psychosis with just regular THC, which, you really didn't see back in the 70s in years past. And so almost certainly that is related to the increase in the THC concentration in the plant. And as a lot of people are enriching the plant to have a much higher concentration of THC. And so in the 70s, your cannabis plant would have like 1 to 3% THC, and now it'll be common for it to be 15 to 20%, even as high as 25%. Um, and and the risk for psychosis is also likely related to, how heavy of a user you are. So also remember that I had said that there are at least like 500 compounds in the plant, and at least 100 other ones are CB1 or CB2 agonists or antagonists, I suppose. So, um, the other possibility is that at least one of these other compounds has some antipsychotic effects. And, by enriching the plant for THC, which is almost certainly pro-psychotic, that you're losing some of that other antipsychotic effect. Uh, so anecdotally, we see three scenarios especially in adolescence. So the first is that they are psychotic for a short time, 24, 48 hours, then it resolves. The other being that it takes a couple of weeks for it to resolve. And then the last is that it's permanent. And uh, we think probably in those cases where it's permanent that that person was probably um, kind of going to be schizophrenic or destined to be schizophrenic, and essentially it just kind of pushed them over the edge sooner than it would have happened naturally. And we see this kind of scenario also with things like meth. So, but again, this is all somewhat anecdotal. All right, long-term THC. So, um, we know that if you smoke or if you use THC on a chronic basis, so that you are more likely to use other substances, so things like alcohol, tobacco, opioid stimulants. It's more associated with a lot of psychological or mental health disorders, so mood disorders, anxiety, PTSD, OCD, ADHD, personality disorders. And again, this is, related to what I had just mentioned, but that it may also be a causal factor in developing schizophrenia. And again, whether those people were destined to have it anyway, we're not that sure, but there does seem to be a much higher prevalence of schizophrenia in long-time chronic THC users. And it is stronger the earlier you use, the heavier you use, and with the higher content. And there are cases where the schizophrenia, I mean, usually schizophrenia develops in kind of young adulthood, where there are people also developing it in kind of later in life. Also, from chronic use, we know that and this from the New England Journal of Medicine, that there's altered brain development. Again, we know that teens have a lot of brain development going on. Um, there's poor educational outcomes, increased likelihood of dropping out of school, cognitive impairment, lower IQ, and diminished life satisfaction and achievement. A number of medical kind of comorbidities. Again, the neurodevelopment we talked about, pulmonary, and whether that's related to just kind of smoking a combustible. It's hard to kind of tease those things out. Increased cancer risk. This is not a this. Most of the increased cancer risk, and again, it's probably related to just smoking combustible. There does maybe seem to be a small risk in testicular cancer related to THC, but most of the other cancer risks are almost certainly just related to smoking. And then small increased risks of MI, stroke, AFib. There is known to be decreased sperm function in number, and then CHS or cannabinoid hyperemesis syndrome, which we'll talk about next. So this is a case we had at our in our hospital. A 16-year-old presents with vomiting and abdominal pain, was having repetitive episodes of vomiting over the last 2 days. It's non-bloody, non-bilious, complains of 8 out of 10 epigastric pain, non-radiating, not relieved by vomiting. He's had similar episodes in the past. And then physical exam reveals mild epigastric tenderness without signs of peritoneal irritation. So pretty common presentation for this, although this could look a lot like a lot of other things as well, right? So, uh, it could be appendicitis or other things. Cannabinoid hyperemesis syndrome, again, is interesting. It was very, very recently described. The first kind of paper that used this term was in 2004. It was in Australia. It was in 9 patients. And then these same authors kind of looked back and they were like, oh, you know what? We had this case in 1996 that was described as psychogenic vomiting complicated by heavy marijuana use. And they were like, yeah, that probably was a case of this as well. And we can just see that there was a study that just looked at ER visits, and that ER visits are tremendously on the rise for cannabinoid hyperemesis syndrome. These are generally younger teens and young adults. The median age is about 20. Um, Again, they typically will have persistent nausea, loss of appetite, abdominal pain, repeated vomiting. Those are common. The hyperemesis period typically lasts about 24 to 48 hours, but certainly could be prolonged. Complications include just dehydration, teeth erosion, renal injury just from the dehydration, electrolyte abnormalities, uh, Mallory rice tears have been noted as, all the way to esophageal perforation, pneumothorax, pneumomediastinum. Torsades because of prolonged QT from electrolyte or abnormalities, superior mesenteric artery syndrome, and then burns. Burns because, as you guys probably know, that the symptoms are relieved by hot showers. And so there is a case report of somebody getting second degree burns because they were sitting in the shower. Um, Anecdotally, there's also apparently people will go to hotel rooms because they run out of hot water in their own home. But all of these things have been at least reported in the literature, at least in case reports. Right now, it is a diagnosis of exclusion, and again, you want to exclude other causes because it can look very much like, a surgical abdomen, and you certainly wouldn't want to miss that. And again, some of the, like I said, some of the sequelae of having cannabinoid hyperemesis could result in an acute surgical abdomen. So if you had perfed your esophagus or something like that, you certainly would also have an acute abdomen. So you definitely would want to make sure none of that was going on. Right now, there's no accepted diagnostic criteria and there's no confirmatory test. So it's a clinical diagnosis. There is this criteria called Rome 4. Now, there's multiple kind of criteria that are at least people have published in the literature. So again, none of them are consensus at this point. Rome 4, I would say, is probably going to be the most popular. Um, and supposedly there's a Rome 5 coming out. Maybe it's come out. I haven't actually checked recently, but so again, stereotypical intractable cyclic vomiting that resembles the onset, duration of frequency parameters in cyclic vomiting syndrome. I'll point out that Rome criteria actually comes is derived from just cyclic vomiting criteria. And then, so patient is usually presenting with these symptoms after prolonged excessive cannabis use, relief of vomiting, episodes by sustained cessation, and then supportive history, pathologic bathing behavior may help symptoms. CHS tends to be a little bit more male. CVS, the cyclic vomiting, tends to be a little bit more female. There's also some evidence that people with cyclic vomiting syndrome, unrelated or not uh, cannabinoid hyperemesis, also use hot showers. So that might not be like that of 100% specific sign or symptom. Um, so the number one treatment of cannabinoid hyperemesis is to stop using THC. Now, that is probably easier said than done. And it does take a little bit of time after you stop using, oftentimes for relief. And it may take some months to feel kind of fully better. And it's okay to continue to use some of the home treatment. So like again, hot showers is probably okay. Again, as long as you're not running into these issues with like burn. Um, and then so patients may be often very reluctant to attribute cannabis to their symptoms, so obviously important to have empathy. There are no effective, right now, we have no effective pharmacologic interventions for uh, trying to stop smoking THC, and probably a combination of things like behavioral therapy are the best. 8% of cannabis users who would just attempt to quit on their own, only 8% will achieve 6-month abstinence. There is a cannabis withdrawal syndrome. It is more things like insomnia and anxiety and irritability, restlessness. So not say like a life-threatening withdrawal like an opioid, and or sorry, like alcohol, and not as kind of uncomfortable as an opioid, but certainly those type of withdrawal symptoms probably do contribute to them or the difficulty in stopping THC use. Again, no FDA approved medications for the treatment of cannabinoid withdrawal. So these are all things that have been used to treat cannabinoid hyperemesis. So again, here I will point out that uh, none of these are FDA approved for that specific indication of cannabinoid hyperemesis. And I'm not going to go through these really in detail. I could do a whole lecture on cannabinoid hyperemesis, but hot water again, topical capsaicin, benzos, antihistamines, antipsychotics, which there are a couple randomized control trials. Um, a drug called apripitant, and then NAC, which you guys may remember from acetaminophen toxicity, is also used. I'm just going to go point out that screening adolescents for uh, THC, this is really for any kind of drug use, but THC included. So there's something called the craft interview, and this is validated in adolescents. Uh, this is the basic craft. There's also craft kind of plus nicotine, which asks more questions. But so basically, you would start off with this and just say in the past 12 months, how many days have you done any of these things? Drink more than a few sips of beer, used marijuana, used anything else to get high? And so if they answer anything but zero, then you'd proceed on to the next series of questions, and that's where craft comes in because it's an I guess a mnemonic. So have you ridden in a car driven by someone who's higher, been using alcohol or drugs? Do you ever use it to relax? Do you ever use it while you're alone? Do you forget things that you did? Do your family or friends ever tell you that you should cut down? Have you ever gotten into trouble? So these are kind of yes or no. And if there's two or more, that um, suggests a pretty serious problem. So you could see that the likelihood or the percent of people having a DSM-5 diagnosable substance use disorder um, is is 64% if you've answered two affirmatives to those six questions. And so this can be done pretty quickly. All right, specifically just looking at the effects of vaping. Um, so first was the EVALI, which is the electronic vaping associated lung injury. And so this was a big deal. Oh man, what was it like before COVID, 2016, 17, something like that, where a number of people in the United States were getting very, very serious lung injury after vaping, and there were a number of deaths. And as best we have figured, that was associated to an adulterant of vitamin E that was added to kind of the vaping solutions. So that mostly went away, although there still are cases every now and then. Well, this will pop up. We also know that there's all these other things in the vaping solution, right? So solvents, flavoring chemicals, and then because the vapes light or heat to a significant temperature, that we know that also you will get kind of heavy metals, you'll get these ultrafine particles that can reach down deep into the alveoli. And we just, I guess, really don't know the long-term effects of those in terms of is there, for instance, a cancer risk, or are you going to get COPD, things like that. We just don't know as much as we do with nicotine tobacco smoke. I, I will say that we think that almost certainly it is safer than um, smoking combustible tobacco nicotine, but whether it's safe or whether there's not long term, I would say that we think that, yeah, there almost certainly is going to be long term effects. And there's especially an important point in this for adolescents, which I'll get to in a second. So, nicotine long term. So, and this is probably where it's really important in terms of a teen's vaping nicotine. So, one, we know that, okay, so first I'll say that it's very difficult to do these kind of studies, right? We're never going to get a randomized control trial. We're never going to be able to get a group of teenagers to smoke and another one's not to. And like, we're not going to be able to do that. I mean, the IRBs wouldn't let us do that. So there's going to be a lot of confounders, especially. So a lot of what we know is based on animal studies. There's not as much human data, and then kind of epidemiologic studies on humans. So almost certainly nicotine is not neurodevelopmentally benign, and the most important thing, uh, or one of the, I think, probably a really important things, almost certainly, is that nicotine we know is going to affect your reward and executive control, and that adolescents are more likely to become dependent. And so, from an adult standpoint, you could look at vaping as harm reduction. Trying to get adults off smoking combustible cigarettes is probably a good thing, but teens are probably then more likely to actually smoke combustible cigarettes when they start vaping. So that's certainly a bad thing. And then there are, again, effects on cognitive function, reduced attention, increased impulsivity, increased anxiety, increased depression. All right. And then specifically kind of going into prevention, this is from, so there's a lot of um, information on CDC website. Uh, this is called the Empower Vape Free Youth Campaign. This specifically, I think, is aimed at kind of like the schools, so teachers, coaches, and principals, not so much necessarily at families or physicians. But again, going into things, this is again from that same campaign, how to talk to students. So, but certainly getting schools involved is a very important part of all of this. And then this is from HHS. So again, it's called the Tobacco Education Resource Library. Again, resources on kind of talking with students specifically. This, again, a resource from Truth Initiative, Youth Vaping Prevention and Resources to Quit. So, again, really hard to do these studies on what is the best way to prevent adolescent use and things like that. But looking at the literature, I think the would suggest that starting earlier is better. So starting in middle school as opposed to starting in high school. Um, and that specifically kind of with parents, um, and having a lot of kind of short conversations, casual discussions, is probably more helpful as opposed to kind of interrogating your teen or having this one big kind of drug talk. Getting schools involved is important, and there are studies that show kind of that family and school works better. Um, and broader substance use prevention. So, kind of addressing all of it, THC, alcohol, and other drugs. And then, really important in our today's society is addressing social media, and the misinformation and other things that you'll see, and kind of the peer pressures that teens will undergo that kind of you know people like me didn't have to go through. So there is, again, I think a lot of this is probably easier said than done. Maybe changing a parent behavior is maybe even harder than preventing use in teens. But warm parenting with clear limits. So something like, I care about you, I want to understand what's going on, but we have firm rules, as opposed to, no, absolutely not, you can't do this, or the other side of it, do whatever you want, just be safe. So kind of warmth without limits is not very protective. And then there's kind of strictness without warmth that can certainly backfire. And actually, there's some evidence that strictness without warmth can actually lead to more kind of secrecy and more likely for them to actually use. And I put on parental role modeling here, and again, easier said than done. But if the parents smoke, then certainly the teen is going to be more likely to. So, again, I'm not sure how to get the parents to stop, but that certainly would be a component of it as well. Um, so school-based programs are efficacious. But they need to be aimed at things like peer resistance training. So how to say no, especially to their peers, correcting exaggerated beliefs like there is this kind of belief that vaping does not have any health effects. Um, Emotional regulation, coping, repeated sessions over time throughout the school year, and then again, peer discussion, peer role play, peer role models are very important. All of these things tend to be better than kind of didactics, like again lecturing to teens, showing them pictures of diseased lungs, things like that just don't seem to work that well. And then from an advocacy standpoint, as pediatricians, we can advocate for these things. And again, we know that these things tend to work: higher tobacco prices and taxes, retail age enforcement, advertising restrictions, smoke-free norms, reduced retail density access, and then packaging restrictions, especially for little kids. So, again, if our society is voted to have marijuana legal, then we need to really make sure that the packages and things like that are child resistant, and go over how to with parents about keeping those things away from little kids. Again, what doesn't work, these kind of one-off fear-based talks, again, they don't tend to work with teens. Um, Peer information, again, the kind of going over just the health effects doesn't tend to work that well. Scare tactics without skill building, and then absence messaging without addressing peer pressure, stress, identity, access, all these things that are affecting teens um, that need to be addressed in conjunction with drug use. All right, and that is the end. Mark, I'll hand it back over to you.
Thank you, and thank you, Dr. Yin. We do have a little bit of time left, so we have a representative from the Ohio Department of Health here to speak about some of the prevention measures that they have as well. So I am going to kick it over to Amy, who is now pulling up her slides. So we'll give a second for those to pop up, and then she will tell you a little bit about some of the programs offered by the Department of Health. And Amy, you are on mute. Just to
We talked about this earlier. I said, these things can make people look really inept when they're not following simple instructions. Sorry about that. So I am the program manager for the Tobacco Prevention and Cessation Program at the Department of Health. And I learned of this talk, and I wanted to kind of complement some of what Dr. Yin has said about nicotine and provide some Ohio-based. I know that he shared a lot of the national resources and provide a little bit about what's going on in Ohio. So one of the things he said a little bit ago was talking about helping the parents quit. And I was going, hey, we can help with that. So the first slide here is talking about the Ohio Tobacco Quit Line. Want to make sure that everybody is level set on this and understands that regardless of the fact of what you're hearing in the news about the federal landscape for nicotine prevention, that we are still funded. We still have the Quit Line operational in Ohio, and it is still serving everyone in the state with free nicotine replacement therapy. So here are all the services offered in the program. There are a number of other different specialized tracks, but we do offer individual group counseling. We facilitated chat with coaches. There is text messaging available. support 24/7 a day. It's 24/7, 24 hours a day, 7 days a week. There's an online dashboard that people can use to go at their own pace and participate in different sorts of. An example is that there's a lung cancer screening prompt that will come up there if somebody's eligible for lung cancer screening. Recognizing most of this doesn't really apply to youth, but certainly those adults are interacting with the youth, and we want them to be able to be healthy and available and good role models. So hopefully, we will be able to connect adults to the Quit line. But then there is this other program that is Live Vape Free. So this is for youth, and this is really what I wanted to get in front of all you today, especially since you're thinking about youth nicotine use and cannabis. I will say that in talking about this, I meant to find out if a young person that's using cannabis is able to experience the Live Vape Free program or if they have to only be using nicotine. I'll have to get back to you. And if Mark would be kind enough to maybe share the answer to that, I'm telling you right off the bat, for some reason, I'm second guessing myself on that. The adult program is for only nicotine use. The youth program, because we're calling it vaping and we know that a lot of youth are dual users, they're using nicotine. I was on a talk a couple weeks ago. It was from youth in California, which obviously I think youth are youth, but California youth are probably a little different than Ohio youth. But it was saying that they use tobacco to wake up and get through the day, or nicotine to wake up and get through the day, and they're using marijuana at night to go to sleep. That's the way they described their day. And I thought, wow, that's shocking. But so they are using it in the same way. They're vaping it. They're obviously the edibles and different things like that. So this program, Live Vape Free, it is for young people that are vaping. I'll have to get back to you on if you're referring someone for cannabis use, but I'll show you a little more details here about the program. So this is for teens that are 13 to 17, but it's also for young adults that are 18 to 26. So the difference in those two is that the 13 to 17-year-olds, we don't provide nicotine replacement therapy to them. It's off-label. There are a lot of studies about the efficacy on that and how much they're using nicotine, what their dose response might be to nicotine replacement therapy. It's only going to be kind of taking the edge off for most people, and maybe not even doing that if they're so heavily dependent on nicotine. Adding nicotine to counteract nicotine can sometimes be effective if we can get to a certain amount of replacement, but it's not happening very often when somebody is very heavily dependent. So that's one of the reasons, but also it's just not approved. It's off label to give it to young people, anyone under age 18. Now, when someone turns 18, they are eligible to receive those nicotine replacement therapy products through this program and also through the phone program that I shared at the beginning. Everything's anonymous, can be participated in directly from any device, mobile device, or, laptop, iPad, web, it's all screen friendly. This is text-based, so they're not going to be talking to somebody on the phone. If someone needs that or someone wants that, they can participate in the Quit for Life program that is really meant for adults, but it's certainly available to any young person over age 13. Sorry, 15. It's 15. They recently changed that. So any young person that wants to talk to somebody on the phone in the traditional way, which not many do. I have a 16-year-old, not many do. But if someone wants to, they are eligible to do that. There's content, there's videos, there's all kinds of quizzes and podcasts, all kinds of things that really appeal to youth. I already talked about the replacement therapy, and then there's the website. It's livevapefree.com. If you go to .org, it's a different website, livevapefree.com. So if it doesn't look right when you get there, check your extension there and make sure that it's the .com. Here's a little bit of sample content, what it looks like. The videos, I've gone through this program myself. The videos are really impressive. They look like something I know my daughter would enjoy watching. They seem very real. They're very, it's young people talking about their experience. There are a number of different modules. I think there's 9 as at last I checked. So there's just a lot to experience in the program for somebody that's really interested in learning more about being able to quit. And then there's an adult advocate program. So if you are in a setting where you want to learn as much as you can about this, you can go to livevapefree.com and then go to the adult advocate section where it talks about how to talk to kids, how to work through anxieties about helping, as a parent, how can you help your child, or as an adult that's working with children, how you can help them get through this. And it really is just about encouraging adults to have those conversations. Dr. Yin was saying gentle parenting, but trying to really be kind of firm in what's acceptable versus what help we can provide you and those kinds of things. So lots of good resources available there. And then the last slide, or no, there's another one after this, but we talked about creating nicotine-free spaces. We do have a model nicotine-free policy for schools. We've been working on creating awareness of this because it's been a little bit, maybe a year and a half ago, we added an alternative to suspension component to our nicotine-free model policy in Ohio. We do score every school in Ohio every year. We have some staff that work on that. Sometimes we have interns working on that. And we look at what policy they have and how it conforms to our model policy, and then work with schools on helping them strengthen their policy. This alternative to suspension piece is keeping kids in school that have been found, maybe they were vaping in the bathroom, or maybe they came onto school grounds and there was a policy that you don't use on school grounds and they were vaping in the car, something like that. Kicking them out of school, or, affecting disrupting their entire flow can really cause a lot more damage. It can send them home to vape more. It's really not teaching them anything other than this is something that can get me out of school, or I'm able to do this more. I don't, the kids that are really intrinsically motivated and want to stay in school and had one bad day, or one day where they, just weren't following the rules, uh, sending them home and suspending them just really isn't what we're looking for at this point. So if you want to learn more about that, here's a resource here that we can share. And then if you have an interest in anything else relating to tobacco cessation or prevention, you can feel free to reach out. Here are some materials we have available. These might be changing based on what we're able to get now, but I just wanted to kind of show you some examples of what we have. There is a link here. I will assume that we can share these slides at the end. There's a link here at the bottom to a product order form. You can click on that and go directly to our website, and there's a full order form that you can look at everything we have available, and we can ship those to you free to use in your patient care if you're interested. So I know we're getting close to time. Sorry, I was trying to rush through there to be sure that I covered everything, but I'll turn it back to Mark.
Yeah, thank you so much. So we have a couple minutes for questions. And Amy had mentioned the slides. If you share those with me, I will send them out to the group. I'm happy to do that. It looked like there were good links and everything on there, so I want to get that out.
Thank you.
Dr. Yin, we did have a question during your presentation about what you've heard about gastroparesis and weight loss in relation to THC use and cannabis vaping.
Yeah, well, that's interesting. So one, I suppose, I mean, cannabinoid hyperemesis could look like gastroparesis. So that would be one thought, and you certainly could get weight loss if it was going on a long time. But I believe there are increased reports of gastroparesis. I mean, the interesting thing also is that it's also cannabis has been touted kind of as a treatment for gastroparesis as well. So yeah, I mean, I think that it could be the number one thing I would first would want to make sure that it wasn't like cannabinoid hyperemesis.
Thank you. Other questions?
There's a hand raised.
Oh, Dr. Harris.
Thank you. I wrote the question about the weight loss gastroparesis, but it was like specifically in relation to like a few SSRIs, because we like had a study about escitalopram and sertraline being two that are metabolized in a similar way as cannabis, and when they're consumed, the side effect profile goes up for the SSRIs as well. And I was curious if that had been like documented in a more formal way. I see it all the time clinically when kids come in, but with like a dramatic weight loss, and then they later disclose that they had been using fairly heavily. But I didn't know if that was common.
Yeah, no, I don't think that is. It'd be interesting. It might be a good case series to publish. Um, but yeah, that's not, I don't think, well described at all.
Thank you. I hadn't even been thinking about cannabis until I saw the ER note and then the disclosure happened 6 months later. And I was like, well, that makes sense.
Thank you, Dr. Harris. All right, well, I am going to close us out. Again, I will send an email with the slides attached as well as information about applying for CME. And if you have any questions for our speakers, feel free to respond and I can see if they can answer those questions for us. I want to give a big thank you to Amy and Dr. Yun for speaking today for us, and then, of course, to the Ohio Department of Health as our sponsor. Again, if you have questions, feel free to reach out to me. Otherwise, I hope you have a great rest of your Wednesday, and we will see you next time. Thank you.